Hey study buddy, this is your local 4th year med student, Eli Chen, and welcome to Pre-Rounds, where we'll talk through a case, review some high-yield topics for exams, and hopefully become a little less confused together. This is the Step 2 version of the case, where the information is geared towards that exam in particular. Check out the Step 1 version of this case if you're prepping for that instead. And lastly, I'm not a real doctor yet, so all the info and sources are taken from the Real Doctors Guidelines listed in the description. And a disclosure, all of this information is for the purpose of education, and none of this should be taken as medical advice. So let's get started with our case. This is a 68-year-old man with shortness of breath. Did he climb a flight of stairs a little too quickly, hop into a surprisingly cold shower, or perhaps win the lottery? I don't know. Let's find out. So first, if a person comes with a shortness of breath, I'm kind of concerned about their stability, and so I want to get a set of vitals first. His temperature is 100.4, so he has a bit of a fever. His blood pressure is stable at 140/100. His heart rate is high at 110. His respiratory rate is high 22, and his SpO2 is low at 85% on room air. A little bit more about his history. He has worsening shortness of breath for the past 4 days, and now he can't sleep. 5 days ago, he had some runny nose, fatigue, and headache, and fever, and all of this kind of went away as his shortness of breath and cough got worse. Exertion or walking makes it worse, and albuterol kind of helps. In other symptoms, he has a chronic cough that's been worsening for the past couple days. He's had this cough for 4 years, going on for most of the year. He's coughing up some white and yellow sputum, but nothing red. He's had wheezing for 4 days and chest tightness as well. He says he is compliant with medication, he doesn't have oxygen at home, he doesn't have a flu vaccine this season, and he has no travel history. Review of symptoms is significant for fatigue, but no night sweats or chills. He doesn't have any palpitations or chest pain. He does have some coughing, wheezing, some shortness of breath, and he doesn't have any swelling of the legs. So when we're looking at differential diagnoses, we want to figure out what is an emergent diagnosis that could be life-threatening that we want to rule in or rule out, and what is non-emergent but still could be a diagnosis. So one of the things I want to consider is definitely COPD exacerbation with his chronic cough that's been worsening and going on for quite a while. This matches up with the definition of chronic bronchitis, which requires at least 2 years of over 3 months of chronic productive cough per year. I also want to consider some infectious source, either pneumonia or a viral etiology, from his fever, his cough, and general weakness and malaise. And both of these match up very well because 75% of COPD exacerbations are caused by a superimposed viral or bacterial infection. Other things I want to consider is CHF or chronic heart failure because of his worsening cough and dyspnea on exertion. I also want to consider asthma, but since it's been going on for a while and he doesn't have a history of asthma and albuterol doesn't help, I think it's less likely. And of course I want to consider acute coronary syndromes or heart attacks, but this is less likely because he doesn't have any palpitations or chest pain, but we'll still work him up for that anyway. And non-emergently, he could have an upper respiratory infection where treatment would just be supportive. Finishing up with a little bit of his history, his past medical history includes hypertension and COPD. He doesn't have any past surgeries. His social history includes smoking 1 pack a day for 40 years. He has 3 drinks of beer a week and no recreational drugs. For home medications, he takes amlodipine and albuterol. And on physical exam, he is generally ill-appearing. He doesn't have any JVD. He does have some tachycardia, but a regular rate and rhythm. And on lung exam, he has some bilateral wheezing and crackles. He also has some accessory and intercostal muscle use when he breathes. And he has some hyperresonance to percussion. He doesn't have any cyanosis or clubbing. And he has no peripheral edema. So immediately, because his vitals were a bit unstable and he was generally ill-appearing on exam, I do want to do some stabilizing procedures first. One of them is treating his shortness of breath and his low SpO2. So when we're thinking about how to give somebody oxygen, we have a lot of different options, ranging from the least amount using a nasal cannula to the most being intubation. We could start with non-invasive methods like a nasal cannula and work our way up to a non-rebreather or possibly intubation, but we can go over the different options for oxygen supplementation in another episode. For the purposes of managing COPD exacerbations, we just want a goal SpO2 of 88 to 92, so not too high. So in order to understand why we want our SpO2 not too high in people with COPD, we need to understand respiratory drive. So usually the main respiratory drive is caused by high CO2, which is detected by our central chemoreceptors sitting in the medulla of the brain, and they tell us to breathe to try to get rid of the CO2. COPD causes chronic hypercapnia because of air retention, and so the chemoreceptors get desensitized. Kind of like if the fire alarm was going off every day in your apartment, you'd soon start to ignore it and not know if there was a real fire. So with COPD, the main driver for breathing now becomes low oxygen, signaling the peripheral chemoreceptors in the carotid and aortic bodies to tell you to breathe. If the oxygen saturation goal is too high, this could lead to a decreased respiratory drive and increased free radical damage from all of that oxygen. So essentially, you would inflate the oxygen saturation in your blood, and your body wouldn't breathe as often. So let's say this patient stabilized with 15 liters on a non-rebreather. We wouldn't need to do more invasive or stronger methods of ventilation, including non-invasive positive pressure ventilation like BiPAP or bilevel positive airway pressure, or CPAP, continuous positive airway pressure, or even endotracheal intubation. And this is a quick aside about CO2 causing our drive to breathe. Swimmers who take advantage of this can have a shallow water blackout, now renamed the hypoxic blackout. So basically, they would hyperventilate before diving underwater to reduce their CO2 levels, and that would delay their urge to breathe while underwater. But while they're doing that, their oxygen levels drop below what their body is comfortable with, and that decreases the urge to breathe. So then they black out from the lack of oxygen when they don't breathe as often as they should. So don't try this at home. Secondly, I would consider empiric antibiotics. And this can be considered for signs of infection, which our patient has. He has a fever, a cough, and previous signs of a viral infection as well. And the options for this include coverage for community-acquired pneumonia, including macrolides, respiratory fluoroquinolones, tetracyclines, or cephalosporins. And you could choose this based on local resistance patterns, affordability, or patient history. And for his shortness of breath, I want some short-acting bronchodilators to help him with his breathing immediately. And this includes albuterol nebulizers if he hasn't already taken his albuterol. You could do 2.5 to 5 milligrams every 6 hours, and also ipratropium nebulizers, which is a muscarinic antagonist, usually 0.5 milligrams every 4 to 6 hours. And finally, for his initial stabilization, I want to start some corticosteroids to reduce inflammation. And this has a delayed effect as opposed to the albuterol and ipratropium that we started that has an immediate effect. This is going to have an effect at about 12 to 24 hours. And our options here are oral prednisone, 40 to 60 milligrams, or IV solumeterol, 125 milligrams for about 5 to 7 days. So this is more long-term. And the most recent guidelines for COPD exacerbation from the GOLD Initiative for COPD, the acronym GOLD, in 2023, they recommended 40 milligrams of prednisone for 5 days plus oral antibiotics for patients with excessive cough and purulence. But new evidence has actually been looking at blood eosinophils to predict magnitude of inhaled and oral corticosteroid effects. So the STAR-2 study in 2024 in the UK looked at treating COPD exacerbations with prednisolone, 30 milligrams daily, only if the eosinophils were high, which they considered as higher than or equal to 2%. And this happened in about 66% of exacerbations. So they actually found that there was no increase in treatment failures and no worsening of lung function compared to standard treatment. And in fact, patients with standard therapy had worse FEV1 measurements after the exacerbation. So maybe checking eosinophils before using steroids for COPD exacerbations could be in the near future. So going back to the patient, what kind of labs do we want? Because of his respiratory distress, I think we can get an arterial blood gas or ABG. We can also get a CBC and CMP, our basic labs, and we're looking for metabolic derangements and possibly anemia or polycythemia. Because we're concerned about CHF, we can also get a BNP. Because we're worried about acute coronary syndromes, we can also trend his troponin. And because of his fever and cough, we can also get a respiratory panel to cover a lot of our upper respiratory tract infections. So for our labs, his arterial blood gas is significant for a pH on the low side of 7.37, PaCO2 high at 50, and PaO2 low at 68. His CBC is significant for a hemoglobin of 16, which is high, and a white blood cell count of 11,000, which is normal. His CMP is significant for a bicarb, which is high at 35, but everything else is within normal limits. And this paints a picture of chronic respiratory acidosis with his CO2 retention, with compensatory metabolic alkalosis. And with his BNP and troponins normal, I don't think it's a CHF exacerbation, and I don't think it's acute coronary syndrome, and we can stop trending his troponins. His respiratory panel came back with flu positive, but everything else negative. Because he's short of breath, we can rule out a lot of things like pneumonia or pleural effusions with a chest x-ray, and so I would want to get that for imaging. And I saw a great explanation of how to read chest x-rays from the International Emergency Medicine Education Project. It's linked in the description, and we'll go over it today. And I had a resident tell me you'll look so smart if you first talk about the quality of the film. So let's put on our film critic hats for a second and talk about quality. So the acronym here is RIPE, R-I-P-E. And this stands for rotation, inspiration, position, and exposure. So for rotation, we want to make sure our clavicles are symmetric and they are equally distant from spinal processes. For inspiration, we want our diaphragm seen at 8th to 10th posterior rib or the 5th to 6th anterior rib. For positioning, we'd want to consider whether this is a posterior anterior or anterior posterior, PA or AP. And usually there's also a lateral film that's taken as well. The standard chest x-ray is PA and lateral, but AP is more conveniently used in a trauma scenario or when the patient can just be sitting up in bed. And the letters tell us the direction of the x-ray beam to the detector. So PA meaning the x-rays are going to go from your posterior to your anterior. And lastly, the exposure, meaning you should be able to see the T4 vertebra and the spinal processes. Underexposed means you can't see any bone details of the vertebra, and overexposed means you see all of the vertebrae, not just T4. And now moving on to the actual chest x-ray, the mnemonic here is ABCDE, and this stands for airway, bones, cardiac, diaphragm, and everything else. So the first thing is looking at airway. We want our trachea midline, our bronchi patent, and no foreign bodies. For bones, we want to trace our ribs for fractures. For cardiac, we want our heart within half of the total width of the diaphragm. Otherwise, this would be called cardiomegaly. For our diaphragm, we want our gastric bubble on the left, our costophrenic angle sharp, and our diaphragm relatively dome-shaped. And for E, that stands for everything else, including tubes, lines, hair clips, anything the patient might have on them. So the chest x-ray for this case, you'd be able to see lung hyperinflation, increased AP diameter on a lateral film, and a flattened diaphragm. And all of this matches our diagnosis of COPD. We also got an EKG, and because this isn't a cardio case, we won't go over how to read EKGs in this episode, but to summarize, we see peaked P waves in the inferior leads, and this indicates right atrial enlargement from cor pulmonale. We also see low voltages in 1, AVL, and V5 to 6. So our final assessment is a 68-year-old man with worsening shortness of breath and productive cough for 4 days, secondary to a COPD exacerbation due to the flu. Our overall plan is admit to medicine. So our first problem on the list is our COPD exacerbation. And we covered a bit about the treatment for this using the mnemonic ABCO, antibiotics, bronchodilators, corticosteroids, and oxygen. Upon outpatient follow-up, we should probably consider scaling up to a long-acting muscarinic antagonist and long-acting beta agonist combo for COPD treatment, because a single albuterol probably isn't cutting it. For his second problem, he has the flu. For this would be supportive treatment, which is included in our COPD management. He also has a chronic problem of hypertension. We would continue his home amlodipine. And his discharge is pending resolving his big bad wolf huffing and puffing. Speaking about discharge, what do we send him home with? So when considering home oxygen for COPD, he would qualify if he had a resting PaO2 less than 55 or SpO2 less than 88. We can also see a PaO2 56 to 59 with pulmonary hypertension, right heart failure, or erythrocytosis. And for this patient, he actually had erythrocytosis seen with a hemoglobin of 16. So the two big takeaways for reducing mortality in COPD are smoking cessation and home O2 at certain oxygen saturations, like we said. So this came from a 2021 study in the UK, which found that the lowest inpatient mortality came from oxygen sats of 88 to 92. And there was an increase of mortality in oxygen sats outside of that range in either direction, higher or lower. Also, if they do happen to get home oxygen, make absolutely sure that they stop smoking, at least around the machine. Oxygen makes the environment around fire burn easier, which means they might get an unwanted mustache and nose hair trim if they decide to light a cigarette. And also in the outpatient setting, we have to consider our seasonal flu vaccines for people with COPD, our pneumococcal vaccines for people who are over 65, including our patients, and our COVID vaccines as well. We can also consider pulmonary rehab or physical therapy, and this actually has a mortality reduction if started within 90 days of discharge. And our last section is on curiosities and conundrums, where this episode's rabbit hole that we go into is about quitting smoking with e-cigarettes. So we know that quitting smoking is the only proven method to decrease the progression of COPD, but what if they just switch to e-cigarettes? Hit that jewel, as the kids say. So I did some digging on this. The original e-cigarette was made by a Chinese pharmacist, Han Lik in Cantonese, or Han Li in Chinese, and this was made in 2003 to serve as an alternative to traditional combustible smoking. But how do they work? So e-cigarettes use a battery to heat and vaporize a solution of water, propylene glycol, glycerol, and flavorings. And to put this into context, propylene glycol and other glycols make up the thick vapor created by fog machines. So imagine you're at your middle school Halloween dance with streamers and a cheap fog machine lining the entrance and just taking a big huff of that. And compared to the cigarettes that you light, it does reduce exposure to many carcinogens like acetaldehyde, which cause the hangovers after drinking, and formaldehyde, which is in the production of fertilizer, paper, and also as a preservative. But the amount of carcinogens that you're inhaling is not zero. You're still inhaling some of them. So how well do they work? A 2014 randomized controlled trial looks at patients who didn't want to quit smoking, who switched to e-cigarettes, and they found that 34% stopped in 2 months compared to none of them that stopped in the control. And one small study of 39 patients in 2020 saw that switching over to e-cigarettes decreased COPD exacerbations over 5 years and had improvements in symptoms through the 6-minute walk test and a self-reported symptom survey. In general, e-cigarettes are less toxic, could help stop smoking altogether, and could have some benefits to self-reported outcomes. So it looks like so far it can't be worse than lighting a cigarette, but there's still a risk of EVALI, which is e-cigarette and vaping associated lung injury. It kind of looks like hypersensitivity pneumonitis on CT, but in about a quarter of the cases, they need non-invasive ventilation, and another quarter need intubation and ventilation. So it sounds a little better than cigarettes, but it's still not great. So to summarize our teaching points, we discussed the diagnosis, workup, and management of COPD. Remember our mnemonic of A, B, C, O, antibiotics, bronchodilators, corticosteroids, and oxygen. We also went over how to read a chest x-ray. We looked at quality with ripe, rotation, inspiration, position, and exposure, and our systematic method to go through a chest x-ray using A, B, C, D, E. Airway, bones, cardiac, diaphragm, and then everything else. So that wraps up the case for now. Feel free to check out our other cases on the podcast in the meantime. Drop a comment to let us know how we're doing, and next time you pass by your friend who's always a tad bit too stressed, tell them that they are a COPD. A corny, optimistic, pre-doctor. It's in the ICD-10 codes. I don't make it up. All right, see you in the next one.